to get started. Just a reminder that any questions that you may have can be put in the chat box on the bottom left-hand corner of your screen. You also be asked to utilize that for any of the questions, the exercises that we do today. And we will get started. Welcome to Practice Management Institute's Distance Learning Program. We hope that the information contained herein will give you valuable tips that you can use to improve your skills and performance on the job. And today's class is session 2. It's the final session of the ICD10 Coding for the Medical Practice with your instructor, Lisa Majeski-West. And today we are going to get started on Chapter 7, that's page 53 in your manual. And I will turn it over to Lisa.
Thank you, Jessica. Appreciate that. And good evening, everyone. Thank you again for spending the next 3 hours of your night with me. I know that many of you probably have some things that you'd rather be doing than watching TV, especially since AGT is on now for the summer. But hopefully you all have some type of a DVR and you can tape your favorite programs and spend some time with me now finishing up this coding class that we're teaching for the medical practice. And so I just wanted to take a little bit of time to review what we talked about last night so that we can make sure that everybody is up to speed and that everybody's head is kind of in the game. Last night we spent quite a bit of time, probably about half the class, talking about some of the general coding rules and the conventions. And one of the things that I would strongly recommend for you, if you are listening to this webinar and you code for a particular specialty, I believe that it would be very, very important for you to read through the general coding guidelines that are found in the front part of the coding manual, of the ICD10 Coding Manual. And also many of the general guidelines were contained in the earlier chapters of your workbook, so you can find some of them there. But also I would encourage you to read through the chapter-specific guidelines for coding in each individual chapter. So as we discussed last night, there are a number of different coding rules that it's important for you to follow, not just how to look up codes and how to assign codes. After a while, that becomes the easy part. The part that requires some finesse on our part is knowing how to code combinations of codes, how to assign code by priority, so what to code first, what to code second, knowing when additional codes are necessary, and so on and so forth. And so it's not just a matter of checking a keyword in the alphabetical index and then looking it up in the tabular and finding that code. You also have to read your coding book for chapter-specific and general guidelines that relate to the coding rules that might apply for the particular code that you are working on at the time. So, you know, many of us, just to kind of give you an overview of coding in general, many of us who are on this call are working as coders, and as such, what happens if you're working as a coder, you're being given a doctor's note, an op note, so to speak, or a SOAP note. They're all the same, it's just different wording for it. And using the words that the doctor or the healthcare provider is giving you, you are extracting the ICD-10 codes and the CPT codes, which are the procedure codes to bill and to place on a claim for payment of services. And so it's very, very important, obviously, that as a coder, you are giving your billers, if your biller is a separate person and you're not also the biller, that you're giving your biller good data in which to submit claims so that the reimbursement to your provider is maximized. And also, as a coder, it's our job to mitigate fraudulent billing by making sure that we are only coding what we can find on the source document. Sometimes doctors will not have coders. They will do their own coding. And in that case, what will happen is the doctor will submit, or the healthcare practitioner will submit the code to the billing office, and the billing office may or may not have access to that source document to verify whether that code is actually a legitimate code or not, and whether that code is supported by the documentation. You know, yesterday we spoke a lot about this. We spoke a lot about how important it is that the documentation mirror the code. And so as a biller, if you're not doing the coding yourself, but all you're doing is picking up the codes from the point at which they're given to you, you're still responsible for general knowledge of ICD10 coding and CPT coding for that matter, and you'll also be responsible for knowing how to read a source document, because it's going to be your job to do cursory audits of your provider's documentation, so that when you're sending a bill out, you can be assured that the bill that you're submitting to the insurance company is a legitimate bill. If you remember last night, what we talked about on the bill is a CMS 1500 claim form is the standard form that's used to bill out services and procedures to the insurance companies, including Medicare, Medicaid, and commercial carriers. And so when you submit that bill, there's a box at the bottom of the form called Box 31, and Box 31 is where the healthcare provider signs that claim form. Whether they sign it by hand or whether they sign it electronically, it's still considered a legal signature of that healthcare provider. And the healthcare provider, by signing that form, is attesting to the False Claims Act. And the False Claims Act, basically, if you ever looked at a red paper original claim form, on the back side of that claim form is all this little writing, and that's the contract that we are actually signing with the insurance carrier, stating that we are not submitting false claims. And so having a knowledge of ICD-10 coding and CPT procedural coding is so important in ensuring that your provider is being protected against submitting false claims, and against the possibility of recoupments and even more severe penalties like civil money penalties and even criminal penalties if they are continuing to bill fraudulently. And so this ICD-10 piece is super important. It used to be that ICD-10 coding wasn't as much of an issue for us as coders and billers, because ICD-9 coding was very non-specific for the most part. The codes were very easy. There were only 13,000 codes versus 71,000 codes. And if a provider put in a diagnosis code for you to bill out against a procedure, it was normally a fairly generic, non-specific code. They did get fairly specific, but not to the extent of ICD-10. ICD-10 introduced laterality. They broke anatomical sites down into minute pieces. So, for example, in ICD-9, a breast was a breast. Well, in ICD-10, you not only have the right breast and the left breast now, but you have the breast broken down into quadrants, and you also have the nipple and the areola. So the the diagnosis of let's say a tumor in the breast has to be extremely specific in comparison to what you were doing in ICD-9. So it's very important now that coders have a good working understanding of ICD-10. And so what we did, we talked about those coding conventions, the general coding rules, and then we began to get into some of the chapters. And as you know, in ICD-10 there are 21 chapters, and most of these chapters are broken down by types of conditions and also by anatomical sites. And so last night we were able to get through coding a few exercises out of each of the first 6 chapters in the book, and tonight what we're going to spend the rest of our time on until 9 o'clock or until we're done is well, we'll stop at 9 o'clock, but maybe we'll get done sooner. I don't believe we will, but possibly we will. And anyway, we will be coding chapter 7 through 21. Okay, so, and the way it's going to work is the same way it worked last night. We're going to review the chapter overall. We're going to talk about the chapter-specific coding guidelines for that particular chapter and some of the things that you have to pay particular attention to if you're coding in that chapter. And then we'll be shown 5 coding exercises, of which we'll do 1 or 2 depending on how much time we have. The other 3 you'll be able to take home with you, so to speak, even though you probably are sitting at home right now listening to this. You'll be able to take this after the webinar. A recording of the webinar is going to be provided for you that you can go back and listen to. You can fast forward, you can pause it, you can go back, and you can really work on honing those skills by doing the rest of the exercises on your own. So without further ado, let's go ahead and get started with Chapter 7. Chapter 7 is actually one of the few chapters from that in ICD-10 is different than ICD-9. In ICD-9, diseases of the eyes and ears were all combined into one chapter, and now Chapter 7 and Chapter 8 have separated those two anatomical sites. So Chapter 7 are diseases of the eye and adnexa, and then Chapter 8 is diseases of the ear and mastoid process. And so let's look at Chapter 7, diseases of the eye and adnexa. Some of the more common coding scenarios that you're going to encounter in diseases of the eye and adnexa are going to be glaucoma, cataracts, and general diseases that pertain to the eye. So the main thing that we need to know are on the general coding guidelines. Number 1, and this starts on chapter page 53 of your workbook, and then I'd also like you to be in Chapter 7 in your ICD-10 manual. So make sure your page is open to Chapter 7 of your ICD-10 manual, and that starts on page 500. If you have the 2017 book, it would start on page 558. There are some chapter-specific guidelines with coding examples on 558, and then 559 we start with the actual codes. And so taking a look at some of the general coding guidelines for Chapter 7 out of page 53 of your book, it does say, note, use an external cause code following the code for the eye condition, if applicable, to identify the cause of the eye condition. Now, and this typically deals with eye conditions that are a result of an injury. And so if it was an eye injury, you're going to need an external cause code. So, you know, one that I could give you an example of is you're in your kitchen and you're boiling some water, and some boiling water flies up. It's boiling very, very vigorously, and it flies up into your eye, and you sustain a small burn actually on the lens of your eye. Okay, so if that was to happen, then you would assign the code for that injury of the burn to the lens of the eye, and then you would also assign an external cause code as to what happened, and that's what the external cause codes are. And believe me, we will be discussing external cause codes in detail tonight. So make sure if it is an injury to the eye that you are assigning external cause code. There are also excludes notes, and if you remember our general coding guidelines from last night, excludes 2 generally means that if you have a condition that is present as well as the eye condition, those 2 conditions can be coded together. And so you'll see that on page 53 there are certain excludes 2 notes that would apply certain conditions originating in the perinatal period, certain infectious and parasitic diseases, complications of pregnancy, congenital malformations, diabetes-related eye conditions, endocrine, nutritional, and metabolic diseases. So in other words, if you have diseases within those categories that are causing a condition in the eye, then you can code both conditions together. That's basically what an excludes two code means. And so the chapter contains several blocks of codes: disorders of the eyelid, lacrimal system and orbit, disorders of conjunctiva, disorders of the sclera, cornea, iris, and ciliary body, disorders of the lens, of the choroid and retina, and so on and so forth. And you'll notice that there is an entire section for glaucoma. Glaucoma does have some very chapter-specific coding, and so if you look on page 54, you will need to make sure that when you're assigning the code for glaucoma, you would assign, number one, as many codes from category H40, glaucoma, as needed to identify, one, the type of glaucoma, the affected eye, and the stage of glaucoma. And one of the things that when you're dealing with if glaucoma is in both eyes, that means it's bilateral. If the stage of the glaucoma is the same in each eye, then you can code the bilateral component. However, if you have stage 1 glaucoma in the right eye and stage 3 glaucoma in the left eye, you're going to have to code those eyes separately instead of using the bilateral component. And if you remember, you'll see this very clearly in this chapter, because we now have a pair of organs, and so whenever we have a pair, we have the possibility of utilizing a bilateral diagnosis code, meaning that both of the pair of organs are affected. And so because of that, there are going to be the bilateral component. Generally, as we discussed yesterday, a condition that is affecting the right side of the organ, or the right organ or pair of organ, is going to end in a number 1 in the diagnosis code sequence. If it's in the left eye, it's going to end in a number 2, and if it's in both eyes bilaterally, it's going to end in the number 3. And so you'll see that many of the codes in this chapter will have that bilateral component, but do remember that for glaucoma, if there are different stages, you're going to need to code those eyes separately and not use the bilateral component, okay? If the patient is admitted to the hospital, and this is number 4, page 55, and the stage evolves, let's say they're admitted with stage 1, and then through their admission process and through their stay, the stage evolves during the admission, you would assign the code for the highest stage that's documented, okay? For indeterminate stage glaucoma, you would assign a 7th character, and that would be number 4 for indeterminate stage, and this would be based on the clinical documentation. So basically, remember we talked about if your physician or healthcare practitioner doesn't stage the glaucoma, then you won't know, so you're going to have to assign an indeterminate stage, and then you would add the 7th character 4. The 7th character should not be, the 0 should not be confused with 4, which should be assigned when there is no documentation regarding the stage of the glaucoma. So for example, if there is documentation about the stage, but it can't be determined by that documentation, okay, then you would use 4. But if it doesn't say anything about the stage, then you would use the 7th character 0. All right, so those are really the only chapter-specific guidelines that you need to know about in this chapter. So we're going to go ahead without further ado, and we're going to go to the coding exercises. All right, here we go. So, is this chapter 7? No, this doesn't look like chapter 7. I went backwards. There we go. Here we are. Okay, primary, let's do the first one together. We're going to do primary open-angle glaucoma, mild stage, right eye. So just in review, when you're looking up a code in the ICD-10 code book, you're going to go to the alphabetical index at the front of the book, and you're going to look up the condition. Once you look up the condition, then you will be given the code, or at least the base code, and from there it is absolutely mandatory that you go to the tabular, which is the chapter that contains all of the codes themselves in numerical order, and you're going to find that code and look for any specific coding rules that apply to that particular code. So let's go ahead and start with this one. This will be a fairly easy one, and we'll go to our index and let's look up glaucoma. And again, use your chat box. And okay, we've got our Speedy Gonzalez train. She already found it on page 157. So let's go to page 157. And this will help because if you can find it in the keyword index and you can tell us what page it's on, then we can do more of them and we can work on more of the problems. So we have glaucoma, page 157. And we are looking for open-angle glaucoma. So let's see if we can find that. Now I have angle closure primary. We may have to turn page. Open angle is on page 158. About halfway down the first column, we have open angle. And then we have primary, so open angle, and you see how it indents to primary. So basically this is primary open angle glaucoma is H40.11, and then of course there's a checkbox, which means it's going to be a higher level of specificity than that. So let's go to H40.11 and look that up. Here we go, page 581 is primary open angle glaucoma, and this is going to be a mild stage in the right eye. So we're going to be looking for primary open angle glaucoma, right eye is H40.111, and then we have to go to the 7th digit. You see how that 7th digit is there? Next to the H40.111, there's a checkbox that says check 7. And what is the 7th digit? To find the 7th digit, you always go up to the main term. It's either the 3 or 4 digit code, and you're going to look for the pink box that says one of the following 7 characters is to be assigned to each code in subcategories H40.10, 11, 12, 13, and 14 to designate the stage of glaucoma. So in this case, it's primary open-angle glaucoma of the right eye, H40.111, mild stage, and so that's going to be a 7th character of a 1. So it's going to be H40.1111. All right, let's do the next one, capsular glaucoma with pseudo-exfoliation of lens, bilateral, moderate stage. So if we go back to page 581, I'm sorry, page 158 of our book, because that's where we found glaucoma, let's see if we can find this one, capsular glaucoma. That one is going to be in, okay, so if you look at the bottom of 157, it says glaucoma capsular with pseudoexfoliation of lens. Okay, that's perfect. And then it says C glaucoma open angle primary capsular. So now we have to go to 158. We have to go open angle primary capsular with pseudoexfoliation of lens H40.14. And again, we have a checkbox. So now we move back to H40.14, which you will find on page 582. And we're looking at a bilateral moderate stage. Now, you'll notice that this one applies to this chapter-specific coding rule. So there's no indication that the stage is different in each eye. So we can assume that the stage is the same. It's moderate in both eyes, so we can use the bilateral component. So H40.14, which is capsular glaucoma, with pseudo exfoliation of lens, bilateral. And then the moderate, we have to go back to that pink box under the H40.1 code, and the moderate stage is going to be a 2. So the code is going to be H40.1432. All right, I'm going to put the answers to the rest of these up on the board like I did yesterday. And what I want you to do is go ahead and write these down. I'll give you just a few minutes to do that. So while you're writing this down, I'd like us together to look at number 5, because as you begin to actually move into the coding world, when you're reading an op note or a doctor's note, you're going to see something more similar to this than what you've been seeing in your coding exercises. You're going to see a summary, a total summary of that patient's condition. And you'll notice that we have a lot of codes to code in that small summary. So one of the things I would like to encourage you to do when you come across an exercise like this one, where you're going to have, and you'll know how many codes you're going to need to find by the number of lines that there are. So if you looked at page 56, you've got 1, 2, 3, 4, 5, 6 lines. It means that there are 6 diagnosis codes in that one statement alone, okay? And so what you would need to do is you would need to take apart that note. The way I do it is I use stoppage points. So for example, let me see if I can demonstrate that with my pencil. Here we go. So here's my pencil. So I have a patient being seen for an encounter for exam of eyes and vision with abnormal findings. That's one diagnosis right there. Okay. The patient has essential hypertension. That's another one right there. Okay. Is essential hypertension. Headache. There's another one. Family history of blindness and vision loss. There's another one. Okay. Right eye pain. There's another one. And vitreous floaters in the left eye. So there's another one. So we have 1, 2, 3, 4, 5, and 6, okay? And so when you're looking at these different scenarios, don't get freaked out by seeing 6 lines and thinking, oh my gosh, how am I going to get 6 diagnosis codes? I promise you, if there are 6 lines in there, you're going to have the answers within the op note. You're just going to have to break it down and read it carefully. And so now the question is how do you sequence those codes? So basically what we're looking at here is, look at how this, first of all, you would sequence the reason for the visit, the exam with abnormal findings, okay? Then why is, even though vitreous floaters in the left eye is the last thing in the op note, why is it second? It's second because that's the reason for the visit. It's for exam of eyes and vision. So what you're going to do is you're going to diagnose the vision problem first, because that's why the patient is being seen, okay? And that is, in essence, the most acute condition. Then the next thing is any type of eye symptom relating to the eye. So the next thing is the right eye pain. So you have vitreous floaters and the right eye pain. Then you can use the hypertension code, that the patient also has hypertension, and then the family history code, the Z code for the family history, is always last. And so it's really just a matter of knowing, using a little bit of common sense, but also if you go through the coding book carefully, the coding book will tell you what to code first and what to code second. But I also want you to think about it logically as well, so that it makes sense to you and you're not just reading and doing it by rote. You need to understand why you're having to sequence those codes in a certain way, and that is the reason why. So I just wanted you to make sure that you kind of do this with your questions. And for those of you who are taking my class, my coding proficiency course, this is going to help you in your final exam, because in the final exam you're going to have an op note like this that you're going to have to break down, and you're going to have to figure out what those codes are. And so just make sure that you know how to do that and you're comfortable breaking down those codes. Okay, let's move on now to Chapter 8, Diseases of the Ear and Mastoid Process. And if you'll find the chapter-specific guidelines or chapter notes anyway on page 57 of your workbook. You'll also find it in the ICD10 2017 coding book on page 604. And so let's just take a look at the following notes. They're going to be essentially the same as Chapter 7. So if there is a disorder of the ear that is a result of an accident, then you'll need to code also the external cause, following the code for the ear condition to identify the cause of the ear condition. So let's say the patient has a ruptured eardrum, and they had a ruptured eardrum because they were in close proximity to a bomb blast or some type of loud blasting noise. You would then find that external cause and code it in pair with the ruptured eardrum. And you also have the same excludes 2 notes that you had in Chapter 7. So there are conditions in other chapters that will also relate to conditions of the ear, and you can code them together when both are present. This is a new chapter in ICD-10, and back in ICD-9, diseases of the ear appeared in the nervous system section because they didn't really have room for the disease of the ear to have their own chapter. There are no chapter-specific guidelines for this chapter at the current time, like there is in the eyes, where we have that chapter-specific guideline for glaucoma. In the ears, we do not have that. And you see that there are just a few blocks. There's diseases of the external ear, diseases of the middle ear and mastoid, diseases of the inner ear, and other disorders of the ear. And then you also have the H95 codes, which are the intraoperative and post-procedural complications and disorders of ear and mastoid process not elsewhere classified. The ear disorders in ICD-10 incorporate much greater specificity than ICD-9, including the location of the ear, whether it's the external, middle, or inner ear, the laterality, right, left, or bilateral, or unspecified, whether the disorder was caused by injury or surgical complication, and whether to use an external cause in association with the codes assigned from this chapter. So really nothing major to know about this particular chapter. So let's just go ahead and go right to the exercises. All right, so the first one, we have impacted cerumen bilateral. And let's go ahead and get to our index. Let's look up the keyword, and first one to find it, please put it down. Please put it in your chat so we can all get there. Doesn't mean everybody doesn't try. $242. And we're going to look for, Dawn has 594. That's interesting. Oh, that's the, I was going to say. Okay, so 242, where in 242 is it? What column? Middle column? Okay, cool. So then we're going to go to 594. Trang said she looked up otitis. That was a good call. And we have H61. H61.23 impacted cerumen, which is earwax, by the way. And we have to code it to the 5th digit, so we have H61.23 because it's bilateral, it's in both ears. There is no particular coding rule that goes with that. There is, once you get to the 5th digit, there's no box next to it saying we have to go to a higher level of specificity. So H61.23 is the correct code. All right, let's do number 3. Acute suppurative otitis media without spontaneous rupture of the eardrum, recurrent right ear, patient has exposure to environmental tobacco smoke. So let's go back to otitis. Let me ask you this question. Did anybody else find the code with another keyword other than otitis? Okay, I guess everybody found it in otitis. Okay, so we're back in otitis. We have acute, and suppurative, and it's in the 3rd column. We have H66.4 or H66.00 acute, and then we've got without rupture of eardrum, recurrent H66.00. So I think we're in the right place. It's in column 3 on page 242, about 2/3 of the way down or 3/4 of the way down. Let's go to H66.00. And we have several choices. So we have acute suppurative otitis media without spontaneous rupture of the eardrums. So we're in the right place. Now we have the recurrent right ear, which is H66.004. Elva, thank you, because that's what I found it under, was impacted. On the last question, instead of finding it under otitis, I found it under impacted. I was you. I wasn't, yep. So that's where I found mine too. So back to this one, acute suppurative otitis media without spontaneous rupture of eardrum, recurrent right ear. So that is your first code. And then we have the patient has exposure to environmental tobacco smoke. Go back up to the H66 family name, okay? And it says under H66, which means when you have the red instructions, it applies to all the codes in H66, okay? So it says use additional code to identify exposure to environmental tobacco smoke, exposure to tobacco smoke in perinatal period, history of tobacco dependence. So you have exposure to environmental tobacco smoke is Z77.22. Now, one of the things I do want you to notice, because, you know, obviously we have to not only do, as coders, we have to code, but we have to code quickly because you're coding a lot of op notes every day. And you'll notice that under the exposure to environmental tobacco smoke, it gives you the Z77.22. But what I want you to look at, go down a little bit ways and look at tobacco dependence, where you see F17 point dash. If you see a code like Z77.22 and it's encapsulated in parentheses and there's no dash after the last digit or the last number, that means that that's the code. But if this had said patient has a history of tobacco use, then we would have to go to, or tobacco dependence, then we would have to go to F17 point and look at all of the different choices we have there, okay? So just make sure you're aware of that so that you can code a little bit more quickly, especially when you're using those Z codes for patient family history and so on and so forth. So here are your answers. I'll give you a few seconds to write them down. Jessica, quick question. Can everybody see the chat bar?
They can see just what you or I say.
Okay.
They can't see each other.
Okay. So guys, Trang made actually a really good point in the chat bar, and not everybody can see it. But she said you can take a screenshot of these answers on your phone if you want to, so that you don't have to frantically write things down. So that's another option for you if you don't want to write all the answers down, and then and that actually keeps the answers off of your workbook to where you can do the work and then maybe go back to your screenshots and take see if you got your answers correct. So that's a great idea, Trang. Thanks for sharing that. Okay, let's move on to Chapter 9. This is one of the more widely used chapters in the code book because it deals with diseases of the circulatory system, and this is where you're going to have your hypertension codes, your cardiac event codes, and so on and so forth. And so there are definitely chapter-specific guidelines that you need to know, and if you code cardiology, it's going to be very important for you to know these chapter-specific guidelines pretty cold. If you don't do a lot of cardiology coding, just know that there are a number of chapter-specific guidelines that you must refer to if you ever are put in a position to where you have to code from this chapter. So let's talk about that. Number one, obviously there are some excludes to codes where if certain conditions from other chapters are present, and there are also cardiovascular problems as well. They can be coded together if both conditions are present at the encounter, and so you can look at those. And of course, those will cross-reference from chapter to chapter. So basically, codes certain conditions originating in the perinatal period will cross-reference back to Chapter 9 as well. You have your chapter blocks, so you can see that you have your rheumatic fevers in the beginning of the chapter. Then you have your hypertensive diseases, ischemic heart diseases, pulmonary heart diseases, cerebrovascular diseases, diseases of the arteries, vascular system, veins, lymphatic vessels, and lymph nodes not elsewhere classified, and other and unspecified disorders of the circulatory system. Coding tips. This is at the bottom of page 59 of your workbook. When a causal relationship is stated, so due to hypertension, or implied in the medical record like hypertensive, the coder is to assign hard conditions to I-50 point hypertension due to. Remember, last night we actually looked at these in a bit of detail because we looked at the hypertension and then the hypertension due to, and we had to realize that there was more than one code because they cross-referenced back to each other. And so classified to I-50 or I-51.4 or I-51.9 to a category from I-11, hypertensive heart disease. And we'll probably do one or more of these in your exercise tonight. So I-50 is heart failure. So you have the hypertensive heart disease with heart failure, and then if you have heart failure, then you have to identify the type of heart failure for those patients with that condition. Okay. Now, if there is not a causal relationship stated or implied in the medical record, the heart condition with hypertension are coded separately, and then you would sequence according to the circumstances of the encounter. In other words, what are you seeing the patient for? What is the chief complaint? ICD10 has combinations codes for atherosclerotic heart disease with angina pectoris. When there's a combination code for the condition, it's not necessary to additionally code the angina pectoris. A causal relationship can be assumed in a patient with both atherosclerosis and angina pectoris unless the documentation indicates that the angina is due to something other than the atherosclerosis. So basically what that means is generally if the patient has angina, it's because they have closing of the arteries or narrowing of the arteries or sclerosis within the arteries. However, there are instances where angina is caused by something else, and if that's the case, then you wouldn't code that. You wouldn't use the combination code. Category I-69 is used to indicate conditions classifiable to I-60 through I-67 as the causes of sequela, neurologic defects, deficits themselves classified elsewhere. These late effects include neurologic deficits that persist after the initial onset of conditions classifiable to I-60.I-67. So let's look at I-69 real quick so you can kind of get a feel for what that means. Let's take a look at I-69. Okay, so basically what these codes are these are your paralytic codes, and that would make sense. So if you have a patient who has, this would be a I-69.0 sequela, which is a late effect following a non-traumatic subarachnoid hemorrhage or cognitive defects. So in other words, the patient has had a mild stroke and now they have cognitive defects. And so if you're treating the cognitive defect and the patient has already had a stroke, then that cognitive defect becomes the primary diagnosis, and then the stroke is the causal relationship of that defect. So just so you know that in that case, for these conditions can arise anytime after a cardiac event, and so you would need to know that those types of codes are found in this chapter, in Chapter 9. And also, if you have a patient that is suffering from any type of paralysis, either hemiplegia, paraplegia, quadriplegia, you would need to let them know, the carrier and in the documentation, know whether that paralysis took place on the patient's dominant side. The only way to know that, number one, is to know if the patient is right-handed or left-handed or ambidextrous. Now, if the patient is ambidextrous, the right side will be the dominant. If the left side is affected, unless the patient is left-handed, then the default will be non-dominant. And if the right side is affected, as long as the patient is right-handed, then the default will be dominant. Okay, so just so you know about the dominant and non-dominant sides. The other coding, chapter-specific coding guidelines that you need to know are the coding guidelines for acute myocardial infarction, or AMIs, and whether ST elevation is present and or non-ST elevation. So you have STEMI or non-STEMI or NSTEMI. ICD-10 CM codes for AMI identify the site. So whether it's on the anterolateral wall of the heart and so on and so forth. Codes I21.0 through I21.2 and I21.3 are used for STEMI AMIs. I21.4 are used for non-STEMI AMIs and non-transmural myocardial infarctions. For encounters, remember this is important because it will, you probably are going to have a coding exercise on this, so you may want to highlight the bottom of page 60. For encounters occurring while the MI is equal to or less than 4 weeks old, including transfers to another acute setting or post-acute setting, and the patient requires continued care for the MI, the myocardial infarction, codes from category I-21 may continue to be reported. The coder and the clinician will note that this time frame differs from the acute stage of an MI in ICD, and write down 10, cross out 9 and write down 10, CM, which is 0 to 8 weeks. And this will make sense when we start looking at the op note. Okay, for encounters, going on to page 61 at the top, for encounters after the 4-week time frame and the patient is still receiving care related to the MI, the appropriate aftercare code should be assigned rather than a code from I-21. Okay. For old healed MIs not requiring further care, I-25.2, old myocardial infarction may be assigned. The revised guidelines for Chapter 9, you have the hypertension in and of itself, which is benign essential hypertension, is I-10. It's a 3-digit code. But if you have hypertension with heart disease, with chronic kidney disease, or with hypertensive heart and chronic kidney disease, or hypertensive crisis, you have got to know how to sequence those codes. So pay attention to the code sequencing for that type of hypertension, hypertensive chronic kidney disease, or heart and kidney disease, and you'll find those specific instructions on page 62 of your workbook. Okay, so let's take a look at our exercises in this section. So we've got the first one. It's hypertensive heart disease with acute systolic congestive heart failure. So we're going to, for the sake of time, because we already know what those codes are, okay, if you were going to the index, you would look up hypertension, and then it would take you to the I-11 categories. So let's go to I-11. Which is hypertensive heart disease. And then you're going to have the hypertensive heart disease with heart failure. So it's with acute systolic congestive heart failure. So it's going to be the I-11.0 hypertensive heart disease with heart failure. And then it says use additional code to identify the type of heart failure, I-50. So the acute systolic congestive heart failure is going to be the I-50 code. So this code is actually broken down into 2 separate codes. And again, taking let's do this. Okay, taking my pencil, you have hypertensive heart disease, is the 1 code. Then acute systolic congestive heart failure is the I-50 code. So then we go to I-50. And I-50.2 is systolic congestive heart failure. I-50.21 is acute systolic congestive heart failure. So the code would be, and it says when you look at the I-50 code and you look at the top of the main term, which is the 3-digit code for heart failure, it says code first, heart failure due to hypertension, I-11.0. So you would code the I-11.0 first, followed by I-50.21. Okay, so let's look at number 2. Patient has been diagnosed with a STEMI, myocardial infarction involving left main coronary artery. Patient suffers from tobacco dependence, has smoked cigarettes for 20 years. You can't, Cindy, any idea? Cannot get audio on my computer. You have to call in. There's a phone number to call in. We're all on phone. Maybe, Jessica, you could put the telephone number, well, the telephone number for the audio controls in the chat for everybody. I think we have some person who can't get audio. Take a look at the tab and there's a volume button. Oh, okay. All right. So let's go ahead to our keyword. First person who finds it, go ahead and let us know in the chat box where that keyword is. I looked up infarction, so I found under infarction, and then I went to myocardium or myocardial, which is on page 181. And then we have further on down ST elevation, STEMI, I-21.3. And then we have involving, going on down, the left main coronary artery, I-21.01. So page 181, about 3/4 of the way down, you have, I looked up infarct, I looked at myocardium, then I went to ST elevation, or STEMI, and then from there, involving, and then I looked at the type of artery that involves the coronary artery, the left main coronary artery, so I have I-21.01. So that's where I'm going to go in my chapter, is I-21.01. which is ST elevation, myocardial infarction involving left main coronary artery. There's no other indication that I have to code that to a higher level of specificity, so that's the code. But if you go to the top of page 608 under the I-21 family name, where it says ST elevation STEMI and non-ST elevation myocardial infarction, there are some red notes, and the notes say use additional code if applicable to identify tobacco dependence. And so tobacco dependence is F17 point dash. Okay, so that means we have to go, because that's not the code, If there's a dash, it means there's something more specific. So now we have to go to F17, which is Chapter 5. And we have nicotine dependence, but he said it does say cigarettes. So we have F17.21, nicotine dependence cigarettes. And you have uncomplicated, it's not in remission, it's not with withdrawal, and you do have to go to the 6th digit. Well, probably uncomplicated is because it's not an unspecified nicotine-induced disorder, so I would say that the most logical one would be F17.210 uncomplicated, because it's not a nicotine-induced disorder. It is not in remission, and it's not withdrawal. So all that leaves is the uncomplicated. So let's go ahead and take a look at the answers. Yep, F17.210. Again, just take a couple of minutes to go through the answers, and then we'll move on to Chapter 10. We'll probably get a chance to do a couple more chapters, and then we'll take a little break. Like we did yesterday, we'll take a 10-minute break, give you a chance to stretch your legs, clear your head, go potty. Notice I have kids, I would say go potty. All right, let's go ahead and move on. Diseases of the respiratory system. Now these are going to be your pulmonary diseases, your acute upper respiratory infections, influenza and pneumonia, other acute lower respiratory infections, other diseases of the upper respiratory tract, chronic lower respiratory diseases, lung diseases due to external agents like smoke inhalation or tobacco smoke, other respiratory diseases principally affecting the interstitium, suppurative and necrotic conditions of the lower respiratory tract, other diseases of the pleura, and so on. Now, when general coding guideline for Chapter 10, when a respiratory condition is described as occurring in more than one site and is not specifically indexed, it should be classified to the lower anatomic site. For example, tracheobronchitis to bronchitis in J40. Use additional smoke. Use additional code where applicable to identify exposure to environmental tobacco smoke, exposure to tobacco smoke in the perinatal period, history of tobacco use, occupational exposure to environmental tobacco smoke, tobacco dependence, and tobacco use. Obviously, when you're dealing with the lungs, this is going to be one of the key questions to be asked, and you would want to get a very detailed history about a patient's habits of tobacco use, specifically smoking. Okay. General coding guidelines for asthma on page 64 of your workbook. You'll notice that there are characterizations for severity, which can be documented as mild intermittent, mild persistent, moderate persistent, severe persistent, other, and unspecified. So there's also characters to indicate that patient of a status asthmaticus, meaning a chronic asthma, someone who has chronic asthma and acute exacerbation. In other words, an asthmatic flare-up. So there's some examples of that on page 65 that you can look at. There's also a few chapter-specific guidelines for COPD and acute respiratory failure. So for COPD, which is chronic obstructive pulmonary disease, and asthma, it is an acute exacerbation of chronic obstructive bronchitis and asthma. The codes in categories J44 and J45 distinguish between uncomplicated cases and those in acute exacerbation. An acute exacerbation is a worsening or decompensation of a chronic condition, and an acute exacerbation is not equivalent to an infection superimposed on a chronic condition, although the exacerbation can be triggered by the infection. Okay? Cindy, I'm sorry, Jessica, are you reading the note about Cindy as far as the workbook? I don't know if you can email her the PDF for the workbook. Acute respiratory failure as a principal diagnosis. The code from subcategory J96.0, acute respiratory failure, or subcategory J96.2, acute and chronic respiratory failure may be assigned as principal diagnosis when it's the condition established after the study to be chiefly responsible for the hospital admission. And the selection is supported by the alpha index and tabular index. Okay, so just be aware of that as well. If the patient is admitted and the tests indicate acute respiratory failure, it can be coded first. Let's see, what else do we need to know? Influenza, let's go to number 3 on page 66 in the middle. Influenza due to certain identified influenza viruses. Now, why are the respiratory conditions, influenza, pneumonia, in this chapter and not in chapter 1, which were the diseases of the bacterial nature, certain infections and parasitic diseases? These are infections, but these are generally viral infections and not bacterial infections. But more so than that, sometimes they are bacterial, even in this chapter, but more so than that, they're infections that involve the lungs. And that's why they're classified outside of Chapter 1 and classified in Chapter 9, in Chapter 10 instead of Chapter 1. So just so you know that, if you have a disease that is caused, it says, code only confirmed cases of influenza due to certain identified influenza viruses from category J09 and due to other identified influenza virus from category J10. Now, this is an exception to the hospital inpatient guideline in section 2. Most of us do not deal with that as far as the hospital inpatient. We're really dealing with the outpatient, so we would follow the coding rules that are here. Coding should be based on the provider's diagnostic statement that the patient has avian influenza. If you have identified the influenza virus, like if it's bird flu, avian influenza, or some other type of influenza virus from category J09, and so otherwise, you would use the more unspecified code for influenza. Ventilator-associated pneumonia. If you have a patient on a ventilator and they develop pneumonia, this is on page 67. As with all procedural or post-procedural complications, this is a procedural or post-procedural complication for sure, the code assignment is based on the provider's documentation of the relationship between the condition and the procedure. Code J95.851, ventilator-associated pneumonia, should be assigned only when the provider has documented VAP. An additional code to identify the organism should also be assigned. Do not assign an additional code from categories J12 through J18 to identify the type of pneumonia. This is ventilated-associated pneumonia. Okay. Let's go ahead and do some of the exercises from this particular chapter. We'll do number 1, and then I think we're going to do number 3 together because I want us to work on breaking down the op note. So we have acute obstructive laryngitis due to streptococcal infection. So we've got 2 codes. So what is the first place we're going to go look? We're first going to go look for laryngitis, and then we're going to look for infection, streptococcal. So whoever finds the laryngitis code, let us know what page that's on. Laryngitis, page 208. Good job. And we have acute obstructive. So acute obstructive, J05.0. Okay, so this is the first code that we need to look up. Let's go to J05.0. Acute obstructive laryngitis, and then in parentheses they have croup, okay? And then it says use additional code B95 through B97 to identify infectious agents. So at this point, you have a choice. You can either go back to your keyword and look for infection, streptococcal, or you can go straight to B95 through B97 and find it there. And I'm going to go to B95 through B97. So I have J05.0, and it says use additional code. So it doesn't say to code that first. It just says use additional code. So J05.0 is the primary code, and then we're going to look for the streptococcal infection from B95 through B97. B95, Streptococcus, Staphylococcus, and Enterococcus. Okay, so we have Streptococcus group A, Streptococcus group B. We don't have anything in the op note that indicates whether it's group A or group B. We don't have anything in the op note that indicates Streptococcus pneumonia. We have other streptococcus as the cause of disease classified elsewhere, and we have unspecified streptococcus as the cause of disease classified elsewhere. I would say that it would be the unspecified because it doesn't specify what type of streptococcal infection. So the code then, the second code would be B95.5. Okay, let's take a look at the next one. And again, I'm going to get my pencil out. So we are looking at 1, 2, 3, 4 codes, correct? The first code that we're looking for is the mild persistent asthma. And then we have COPD. And we have the patient smokes 2 packs of cigarettes per day. So that's going to be our Z code. And we're also going to, within this code, we're also going to be looking at the history of tobacco use, which is the F code. So the smoking code is probably going to be referenced twice. So the first thing we do is we code the mild persistent asthma. So let's go to our keyword. Let's look up asthma. I have page 31. And I have mild persistent. Mild intermittent, this is on page 32. Mild persistent, which is the J45.30. Okay, and then, but we have with exacerbation in a patient who's also been diagnosed with COPD. So we have J45.31. Looks like that's going to be our code, our first code. And then the second code, let's take a look at that J45.31. And everything you're doing, guys, I'm doing with you. So J45.31, mild persistent asthma with acute exacerbation. So now we go to that J45 code for asthma. If we look at the family name, which is the 3-digit code, it tells us what it includes, and it also says use additional code to identify tobacco dependence and history of tobacco dependence. We have tobacco dependence and tobacco use. So we have F17 and the Z72 would be the two tobacco related codes that we would use in the 3 and 4 spots, but we also have to code the COPD, and the COPD we can look up under C for COPD if it's there. If you find it in the index, please let me know. Or you can look it up under disease. If you go to disease, I would then go to pulmonary, and that's on page 105, and that's in the third column, about halfway down, chronic obstructive, J44.9. And really the op note doesn't specify anything else other than chronic obstructive pulmonary disease. So that would be the code that we would have to use, is the J44.9. Then we would look at, from J45, the tobacco dependence code and the tobacco use code. So tobacco dependence, we would go to F17. And this patient smokes cigarettes, 2 packs a day. So it could be unspecified nicotine dependence, or it could be nicotine-dependent cigarettes uncomplicated. I think either one would work in this case. I'm not sure what the answer is. I'll pull it up here in a second. And then the final code would be the Z code, which would be the history of tobacco use, which is Z72.0. So let me see which code they actually assigned to that. F17.200. Now they assigned the Z72.0 first, and that is okay. These two codes can actually be coded interchangeably. Personally, for me, I like to code my history codes, my Z codes at the end, but this is okay as well. I mean, your claim would not be denied for that. Now, if you had the Z72 code up at the top, and that was your primary diagnosis, then no, that would not fly. As those Z codes can't be used as a primary diagnosis unless it's an encounter code, like encounter for routine aftercare of childbirth, or encounter for immunizations. Then it is the primary code because it's the only code. So anyway, in this case, it could go either way. So go ahead and write your answers down. And we're right at coming up at 7:30. So what I'm going to do is, after you write your answers down, go ahead and take your break. We'll come back at 7:40, and then we'll finish up with the rest of the chapters.
Hello, everyone. We're ready to get started again. I will turn it over to Lisa.
Okay, awesome. So let's go straight to chapter 11, which are your diseases of the digestive system. These are the diseases relating to the stomach and the intestines, and so on and so forth. So the digestive system actually starts with the mouth, the oral cavity and salivary glands, moves on down the esophagus, the appendix. This chapter contains information about hernias, non-infective enteritis and colitis, other intestinal diseases, and it also includes diseases of the peritoneum and retroperitoneum, diseases of the liver, diseases and disorders of the gallbladder, biliary tract, and pancreas, and other diseases of the digestive system. So there are no, again, in this chapter, there are no chapter-specific guidelines for any codes within that chapter, and it is reserved for future guideline expansion there are specific instructions within the tabular list. So within the list of codes itself, you may have some specific instructions that you need to pay attention to. The clinician and the coder will see instructions that may instruct you to use an additional code to identify alcohol abuse and dependence, or to be asked to code or to identify the cause for the external cause or their status of their dentures. And so there are also seventh character extensions that affect the gastroenterology portion, which are abdominal wounds. Now, abdominal wounds aren't going to be found in Chapter 11. They're going to be found in Chapter 19 under the S codes. And that would be the open wound of the abdomen, lower back, pelvis, and external genitals. And then under those codes, you would code also any associated spinal cord injury and so on and so forth. But those really are more for Chapter 19 for those types of S codes. So we just have to remember that there are codes for abdominal disorders in other chapters besides Chapter 11, specifically in Chapter 19, when the abdominal disorder is due to trauma or due to an accident. So really and truly, other than that, it's just the same information that you would need to use to locate your codes, to find them. So let's go ahead and without further ado, do our first two coding exercises. We have fibrosis and sclerosis of the liver due to chronic viral hepatitis C. So we've got two things, fibrosis and sclerosis of the liver, and then chronic viral hepatitis. So if we go to, we might be able to find this under condition. In our keyword. And if you go to condition, it will take you to disease. So let's see if we can find either fibrosis or sclerosis. I did not see anything under fibrosis. Let's see what we can see under sclerosis. And if not, we'll look up liver. Page 142. Fibrosis. And now we can go to liver, which is with sclerosis. It's at the bottom of 142, first column. Fibrosis with sclerosis of the liver, case 74.2. Let's take a look at that. Case 74.2. We have fibrosis and cirrhosis of liver. Code also, if applicable, viral hepatitis, acute or chronic, B15 through B19. And so, again, this allows us, because we have the fibrosis and sclerosis of the liver due to chronic viral hepatitis C, we can go directly to the B15 through B19 codes, or we can go back to the index and look up hepatitis and then viral C. So either way, so K74.2 is your hepatic fibrosis with hepatic sclerosis, and then we can go to the B15 through B19 codes. With chronic viral hepatitis C. So B15 is hepatitis A, B16 is hepatitis B, and B17 B18 is chronic viral hepatitis. And we've got B18.0, and we don't have anything really specified about this chronic viral hepatitis other than it is chronic viral hepatitis C, which is B18.2. So your code is K74.2 and B18.2. Very good. Let's take a look at the next one, gastroparesis due to type 2 diabetes mellitus. So let's look up gastroparesis, see if we can find it there. Gastroparesis, page 157. We have K31.84. Then we have right underneath it, interestingly enough, so I would write down the K31.84 just in the margins, because maybe what we need is we also need the type 2 diabetes mellitus. And so let's go to diabetes. And find due to so diabetes, we have page 97, middle column, diabetes with gastroparesis, and that is E11.43. So let's take a look at those two codes. We've got the K31.84 and E11.43. So we go to the K31.84. What kind of instruction does it give us? K31.84 gives us the instruction of code first underlying disease if known, such as diabetes mellitus, E08.43, E09, E010, E011, 13, etc. And we had E11.43. So even though we have gastroparesis due to type 2 diabetes mellitus, by going to the tabular, we're told that this code is not the primary code. This code is the secondary code, and we have to code the E11.43 first. So your answer would look like this. E11.43 followed by K31.84. You can go ahead and write down the answers to the other questions. Okay. Let's go to chapter 12. Diseases of the skin and subcutaneous tissue. Now, these are your derm codes, but there are some chapter-specific guidelines in this chapter on pressure ulcers, okay, or what is more commonly known as bed sores. Pressure ulcers, bed sores are a very, very common problem in patients who have been hospitalized for long-term, who are bedridden, and so ICD10 took pressure ulcers to a crazy, ridiculous specificity, and they have the stages of the pressure ulcers. So not only on your pressure ulcers do you have to stage them, but you have to measure them as well. And in your physician's documentation, you're going to, especially if your physician works with geriatric patients a lot and deals with pressure ulcers, with patients who suffer from pressure ulcers, you must get them into the habit of measuring and staging those pressure ulcers in their documentation. And so there are different coding guidelines. So let's look at these very quickly. So first of all, you got codes from category L89. This is on page 72 of your workbook at the bottom of the page. Pressure ulcers are combination codes that identify the site and the stage of the pressure ulcer. They're staged at from 1 to 4, with 1 being the least severe and 4 being the most severe. There are occasionally times when you would assign an unstageable pressure ulcer, number 2. This would be based on the clinical documentation. So essentially these codes would be used for pressure ulcers whose stage cannot be clinically determined. Either the ulcer is covered or has been treated with a skin or muscle graft, and pressure ulcers that are documented as deep tissue injury but not documented as due to trauma. The code for the unstageable pressure ulcers should never be confused with the code for the unspecified stage, where there's no documentation regarding the stage of the pressure ulcer. Then you would assign the appropriate code for the unspecified age. So the unstageable means that you know there's a pressure ulcer there, but you can't stage it because there is something blocking that ulcer, whether it is a scar or some type of a scab or a deep tissue, a deep tissue injury or a muscle graft or something like that. The assignment of the pressure ulcer stage code should be guided by the documentation, and patients who are admitted with pressure ulcers that have been documented as healed, so you would not assign a code if the documentation states that the pressure ulcer is completely healed. If a patient is admitted to the hospital with pressure ulcers that are documented as healing or in the stage of healing, then you would want to stage it, because you need to monitor whether that pressure ulcer continues to heal or begins to degrade once that patient is admitted into the hospital. Okay? For ulcers that were present on admission but healed by the time of discharge, you would assign the code for the site and stage of the pressure ulcer at the time of admission. And patients admitted with pressure ulcers evolving into another stage during the admission, then you would use 2 separate codes, one that would be assigned, one for the site and stage of the ulcer on admission, and a second code for the same ulcer and site at the highest stage reported during the stay. Other than that, there are no other chapter-specific coding rules. You would just use the general coding guidelines to guide you. So let's go ahead and do our exercises from chapter 12.